السلام عليكم طلبتنا الأعزاء. Today our lecture will be another lecture in the biochemistry of the reproductive system. It will be about the hormonal and metabolic change in menopause and the andropause. The objective of this lecture to discuss the hormonal change that is associated with menopause and andropause after a definition of each of these two periods, the menopause and the andropause, and then also we will discuss the metabolic change that occur as a consequence of the menopause. Menopause are associated with hormonal change that characterize the menopause, and in addition there will be metabolic consequence of the menopause. So first of all, we will learn about what are the hormonal changes that associated with the menopause. As a consequence of aging, there is a decrease or depletion of the ovarian steroids. This will characterize the menopause. So, as a definition of menopause, it is the permanent cessation of menstruation for at least 12 months following the loss of the ovarian function or the ovarian activity. The ovary will be unable to produce the sufficient amount of estrogen and inhibin, and as a feedback mechanism there will be an increase in the production of the gonadotropin, mainly the FSH in the beginning, in an attempt to stimulate the ovary. Usually the normal age of menopause is around the 51 years, mean age, but it differs according to many different variables. But if the cessation of menstruation occurs before the age of 40, we consider it as a premature ovarian failure. The decrease in the estradiol concentration and the increase in the follicle stimulating hormone that characterize the menopause doesn't start suddenly. These changes started gradually over about 5 years before the actual menopause. So the process is gradual. This transition period is called perimenopausal, and it lasts about either from 2 to 8 years. This is called perimenopausal, and it's characterized by menstrual irregularity and eventually in the menopause. During the menopause, the FSH increase and the estradiol decrease, but the concentration of luteinizing hormone and progesterone remain unchanged. So till now we have 4 changes. First of all, FSH will increase, LH remain unchanged, estradiol concentration decrease, progesterone remain unchanged. Another important change that occur in menopause is in the concentration of androgen. Because the luteinizing hormone concentration doesn't change, so it will still stimulate the ovary to produce the androgen, especially the testosterone and androstenedione. So we have 2 other hormones that remain either the same concentration or increase, which are the testosterone and the androstenedione. And the increase in these hormones are responsible for the hirsutism that may be seen in postmenopausal women. The other source of androgen in the menopausal women is the adrenal gland, as it continues to secrete the androgens. So, because the progesterone, because the luteinizing hormone is still at the same concentration, the ovary is still producing androgen, mainly testosterone and androstenedione, and the adrenal gland also produce androgen. So overall, the ovary decrease its production from estrogen, while the overall concentration of androgens in the female body at the menopause will start to increase. So the ratio of estrogen to androgen will be decreased. So if we want to summarize the hormonal change that characterize the menopause is, first of all, the estradiol secretion from the ovary will decrease, the FSH concentration will increase, luteinizing hormone and progesterone remain unchanged, the production of androgens from the ovary also increase or remain unchanged at least, and mainly the testosterone and androstenedione, and the production of the androgen from the adrenal gland also continue. So the overall ratio of estrogen to androgen in the menopausal women will start to increase. The hormonal change that occurs during menopause have a metabolic consequences on different body systems. The first one is the dyslipidemia. Dyslipidemia is one of the consequences of menopause, and it is characterized by, first of all, we have increase in the low density lipoprotein cholesterol level, which is the bad cholesterol. And in addition, we have a decrease in the good cholesterol, the high density lipoprotein cholesterol, which have a protective role in the cardiovascular system. So the increase in the LDL and decrease in the HDL, both of them will negatively affect the cardiovascular system, the heart and the vessel, and lead to the development of atherosclerosis. The other metabolic abnormality that may be associated with menopause and the incidence may increase postmenopausal is the disorder of carbohydrate metabolism and increase in glucose intolerance. One of the main cause of the increase in the incidence of type 2 diabetes after menopause is estrogen deficiency. It is a very important step in the process of diabetogenesis. But alone, it is not the only risk factor during this period, because usually menopause occur at the 6th decade of age, and there will be another abnormality. Together, all may accelerate the development of diabetes. For example, the abnormal metabolism of vitamin D3, poor diet, decreased physical activity, obesity, and the abnormal adipocytokine profile, calcium deficiency. All these factors play a role together with estrogen deficiency may increase the incidence of carb intolerance. And in addition, in the postmenopausal women, the testosterone concentration usually will increase, and the testosterone usually is associated more with type 2 diabetes than estrogen. And we have also another factor, which is the sex hormone binding globulin, which is the binding globulin for estrogen and testosterone in both male and female. We know that this protein, the sex hormone binding globulin, usually increased by estrogen. It is higher in female. It is increased the estrogen level, and during the menopause, the level of estrogen decrease. As a result, the level of sex hormone binding globulin will decrease. The relation between this globulin, sex hormone binding globulin, and type 2 diabetes mellitus is inverse relation. It means that when we have decrease in the sex hormone binding globulin, as that occur during the menopause, the incidence of type 2 diabetes will increase, and vice versa. After menopause, the incidence of obesity increase, and we have the distribution of fat also will be changed. The prevalence of central obesity is increased. That is characterized by increase in the waist circumference. We have two types of fat in the central region in the abdomen. We have the subcutaneous fat, which is under the skin, and we have the visceral fat which surround the internal organ, intra-abdominal organ. The most dangerous form of central obesity is the visceral fat. The incidence of this visceral fat increase in menopause. Why it is risky? Because it is associated with increase in the secretion of certain molecule called the adipokines or adipocytokines. For example, we have the leptin, ghrelin, resistin, and adiponectin. The profile of the adipocytokines that are associated with menopause is the increase in resistin and decrease in the adiponectin. This profile will be associated with the development of many diseases, for example, diabetes, metabolic syndrome, increase in the blood pressure. Also, it's associated with increased inflammation, change in the immunity, lipoprotein metabolism, coagulation. All will be affected by increase in these molecules. Another characteristic feature of this fat is that the concentration of estrogen is increased in the fat mass by the aromatase system that convert the testosterone or androgen in general to estrogen. Another metabolic effect of decrease in estrogen during the menopause is the change in thyroid function. The iodine uptake by the thyroid gland will decrease during this period. Iodine is a very important part of the thyroid hormone, and it must be taken from the circulation and to be trapped by the thyroid gland and remain in a high concentration we have the sodium iodide pump that make the concentration in the thyroid gland 20 times more than its concentration in the circulation. Iodine is very important part of the thyroid hormone molecule. So during this period, the uptake from the circulation will be decreased. This is the first change. The second change, there will be a slight decrease in the synthesis of the free thyroxine and the free triiodothyronine. The T3 and T4 synthesis may be decreased, but the reverse T3, which is biologically inactive molecule, will increase. Although these changes occur, but still the most important indicator of thyroid function, which is the TSH, the thyroid stimulating hormone, is within the normal reference range, and it can may have tendency to become within the reference range but toward the higher limit. Yani it became upper normal, trying to compensate for the decrease in the iodine uptake and decrease in the free thyroxine and free triiodothyronine synthesis, but still it is within normal. The other system that may be affected during the menopause is the bone metabolism. The estrogen receptors are found in the osteoclast. During this period, the bone resorption is more than the bone formation. So there will be net loss of bone, and eventually there will be osteoporosis. This is mediated by estrogen deficiency. The osteoclastic resorption activity is more than the osteoblastic bone forming activity. So there will be imbalance between the two in favor of increase in osteoclastic resorption activity. And the amount of the bone resorbed is more than the bone formed. Another change in bone metabolism is that the calcium absorption from the intestine during this period will be decreased, and the amount of calcium that is lost in the urine will be increased. So there will be decrease in the intestinal absorption of calcium and increase in the urine calcium loss. If we check for the biochemical marker of bone remodeling, we found that it is increased in the urine. For example, urine calcium is increased, urine hydroxyproline will be increased during this period, and urine deoxypyridinoline also will increase during the menopause. So during menopause, to summarize, the metabolic change that are obvious during this period is the first of all the dyslipidemia in favor of increase the LDL and decrease in the HDL. Also we have abnormality in carb metabolism, glucose intolerance, and increase in the prevalence and of the component of the metabolic syndrome. If you remember, the metabolic syndrome composed of five elements. Anyone who have 3 out of these 5 may have a metabolic syndrome, and the metabolic syndrome is associated with many diseases, for example diabetes, increase in blood pressure, and cardiovascular disease. These 5 components is the increase in the central obesity in the waist circumference, dyslipidemia in the form of increase in triglyceride, and a decrease in the high density lipoprotein. Other component of the metabolic syndrome is the increase in the blood pressure. So during this period, during the menopause, the prevalence of dyslipidemia increase, abnormality in the carb metabolism increase, metabolic syndrome prevalence also will increase, and the key role in all these change may be due to insulin resistant hyperinsulinemia, may be mediated by increase in the visceral fat and increase in the adipocytokines, especially the increase in resistin and decrease in the adipocytokine. Also there will be increase in the oxidative stress, inflammation, and all these also may lead to atherosclerosis. Why it is very important to highlight these metabolic disorder? Because this metabolic disorder may be can be easily diagnosed, are treatable, can be reversed either by checking in a regular way or sometimes using certain hormone replacement therapy. So, but if they are left undiagnosed and untreated, they may affect the quality of women's life and also affect the length of women's life. Many of these diseases, for example, the osteoporosis, the bone loss and osteoporosis can be prevented. The blood pressure can be treated. Screening for carbohydrate intolerance also can be done. Checking for thyroid function. All these may and also highlighting the importance of having a healthy weight, a healthy lifestyle. All these may improve the length and quality of women's life. Similar to menopause, in the male there is a decrease in the circulating testosterone concentration after the 30s or 40s years of age. But it differs from menopause that it is gradual and it is age dependent. So there is no cessation of the completely as in the female. There will be about 1.3% decrease per year in the amount of the bioavailable serum testosterone. The bioavailable, which means the free and the albumin-bound testosterone. This decrease may be due to a decrease in the number of the cell that produce testosterone, which is the Leydig cell in the testosterone in the testis, or decrease in the hypothalamic stimulation by decrease in the gonadotropin releasing hormone pulse amplitude. This is the second factor that may lead to andropause, which is the decrease in the bioavailable testosterone. The other factor that decrease the bioavailable serum testosterone is the increase in the sex hormone binding globulin. When the sex hormone binding globulin increase, this will mean that the amount that will bound to albumin and the free will decrease. The bioavailable means that the bioavailable testosterone is the free plus the albumin bound. When we have increase in the sex hormone binding globulin, we have more testosterone bind to the sex hormone binding globulin and less testosterone bind to the albumin, and the free also will decrease. So these three factors may participate in the decrease in the bioavailable serum testosterone. Either we have the hypothalamic effect, a decrease in the gonadotropin releasing hormone pulse amplitude, decrease in the number of the cells that produce testosterone, the Leydig cell, and increase in the sex hormone binding globulin. Other synonym or other nomenclature for the andropause is called also the late onset hypogonadism, or it is called testosterone deficiency syndrome. Why it is called syndrome? Because it is not enough to diagnose this condition by depending on the decrease in the testosterone alone. It must be accompanied by clinical symptom. Some of the clinical symptoms that characterize this syndrome is the decrease in the muscle mass, decrease in the sexual function, decrease in the muscle strength, decrease in the bone mineral density, change in the mood. All these are clinical features that characterize the andropause or the late onset hypogonadism or the testosterone deficiency syndrome. So to diagnose this condition, we need that the serum testosterone must be decreased, accompanied by at least three of these clinical features: either decrease in the muscle mass or decrease in the muscle strength, decrease in the sexual function, decrease in the bone mineral density, and change in the mood. What is the biochemical marker that can help us to diagnose the andropause? Is the best is the total serum testosterone. But sometimes when we measure the total testosterone, it is not very diagnostic, even if there is a clinical feature of hypogonadism that we mentioned: decrease in the sexual function, decrease in the muscle mass, decrease in the muscle strength, change in the mood, decrease in the bone mass. But when we measure the total testosterone, it is normal. So in this case, we can measure either the free testosterone or we can measure the bioavailable testosterone. This mismatch between the total serum testosterone and the free or bioavailable testosterone result may be due to obesity and advanced age. In this condition, the obesity will lead to increase in the sex hormone binding globulin, and so this will mask the true decrease in the testosterone. If a male at this age have decrease in the testosterone, whether total or the free or the bioavailable, then the next step is to measure the level of the luteinizing hormone. The aim of this step is to find the site of the defect. If the testosterone is low and the luteinizing hormone is high, it means that the defect is primary in the testis. But if the testosterone is low and the luteinizing hormone also is low, in this case the defect is central, either in the pituitary or in the hypothalamus. If we find that the defect is central, then we must measure the level of testosterone. The prolactin hormone also must be measured when we suspect that the cause is secondary to defect in the hypothalamus or the pituitary gland.